Dr. Raghu, my colleague is going to explain about the patient. Raghu, go ahead.
Yes, sir. This is a 64-year-old male on medical management for diabetes for the last 32 years and hypertensive for the last 10 years. Diagnosed to have ostium secundum ASD with moderate PAH in 2010. He reports baseline functional class 2 breathlessness with occasional palpitations and dizziness. There is no history of any chest pain or syncope. 1 month ago, he admitted with lower limb cellulitis, increased breathlessness of class 3, managed with IV antibiotics and optimization of diabetes and hypertension medication. He's an average, he's averagely built, weight of 67.5 kgs, height 164 centimeters, no cyanosis, clubbing or edema. His baseline resting saturation is 96%, BP is 120/60 right upper limb. And cardiovascular examination, pulse is 74 minute, regular, normal volume character, peripheral pulses well felt, no precordial activity, no heaves or thrills. Apex is in the fifth left intercostal space, 2 centimeters lateral to the MCL. S1 is normal, S2 is fixed and widely split. There is an ejection systolic murmur at left upper sternal border, 3/4. This is the chest X-ray showing increased pulmonary plethora.
Freeze.
And ECG showing RSR pattern in the V1, RBBB. This is the transthoracic echo showing dilated RA and RV with large ostium secundum ASD, moderate PAH, RVSP of 51 millimeters of Hg. This is the subxiphoid view showing the ostium secundum defect with left to right shunting. It measured 23 millimeters on transthoracic echo. This is a transesophageal echo showing this, confirming the same. It's the retroaortic rim is deficient, and it measured 22 millimeters on transesophageal echocardiography. These are 3D echoid pictures of the ASD, which is a circular defect measuring 22 into 22 millimeters. So the diagnosis is 22 millimeter ostium secundum ASD shunting left to right with deficient retroaortic rim. Other rims are adequate, dilated RARV, moderate TR, trivial MR, moderate PAH, good biventricular function, no appendage clot. Today's plan is ASD device closure guided by intracardiac echocardiography. So we have done baseline hemodynamics for this patient. His RA mean is 8 millimeters of mercury, RV is systolic is 55, and ED is 10 millimeters of mercury. PA pressures are 55/20 with mean of 32. PV mean is 10 millimeters of mercury. Aorta is 160, 80, 110. And his QP is 7.2, QP indexed, QS indexed is 2.55, QP/QS is 2.8, PVRI is 3.1, SVRI is 40, and PVR/SVR ratio is 0.08. This makes him a suitable candidate for ASD device closure. Today we are planning it by intracardiac.
Show the transesophageal echocardiogram.
Please show the transesophageal echocardiogram once again.
Keep showing the coronary angiogram.
Yes,
and
sir.
Explain the coronary angiogram.
Yes, sir. Show me the coronary angiogram. So this is RAO caudal view, coronary angiogram.
No, first show the echo. Show the.
This is a transesophageal echocardiogram with a large ostium secundum ASD, 22 millimeter size, left to right shunting. Retroaortic rim is deficient. Other rims are adequate. Now we have done a coronary angiogram too.
Color. Okay, fine. Now color out.
There is only mild coronary artery disease with mild disease in the OM. RCA, LAD are normal.
Do you think it's just one large hole, or do you think it's a small fenestration? The question from Edgar, is this one large hole, or is there multiple fenestrations in this?
Actually, it is one single large hole, Dr. Raj. I have come back to this lab. Show the transesophageal once again. Show the transesophageal PowerPoint once again.
Probably echo dropout at the side where the
actually the inferior portion of the fossa valis is very thin, and that is giving those appearances. However, it is more of a sort of a circular defect of somewhere around 23 millimeters. Srija, can you measure? Now we are live and intracardiac. Can you switch over to echocardiography? There is echocardiography live.
So do you plan to go with this size, or do you plan to balloon and do stop flow technique?
No, we don't do balloon sizing. See, right now on a live, can you see the intracardiac echo live? What you are seeing on the frame is the intracardiac echo, and now the measurement is something like 24, 25. Show it live, Srija. Can you see the pictures now?
Yes.
Yep.
Yeah. So what we are planning to do is leave the ice probe in the same location now. And can you get me the 4 French any right coronary catheter? Dr. Raghu, you have done the coronary angiogram.
Yes,
and coronary was normal.
Normal, sir.
Fine. So what was the PA pressure you told? It was something
55
like
by 20, mean of 32, sir.
50 by 20.
Yes, sir.
Okay. So Dr. Raghu says that it is a little mild pulmonary hypertension. What is the QP by QS? 2.8.
Yes, sir.
So we have a right coronary catheter which has gone into the left upper pulmonary vein, and we will be putting in 11 French sheath. You are saying?
Can we see picture in picture with the fluoro also?
Yeah. Please show.
Can I interrupt for a second? It's Claire O'Donnell. Look, this looks a lovely case, and I agree, looks a really nice one to close. And the hemodynamics look absolutely fine. Is there a number in terms of the hemodynamics? What do you watch most for in terms of pulmonary hypertension? Do you look at the QPQS more than the PPR, or what number do you like?
Yeah. So in this patient, I'll again repeat the whole hemodynamics. The right atrial and the left atrial pressures were around 8 mean. The pulmonary artery pressure was around 50, 54?
Yes, 55, sir.
55 systolic with a mean of
32.
Mean of 32 and a diastolic of around 20. So the QP by QS was 2.8:1.
Yes, sir.
What was the PVRI?
PVR was 3.1.
The PVRI was 3.1. So with a shunt of 2.8:1 and a PVRI of 3, I think the question of pulmonary hypertension is possibly, it is just hyperkinetic and it's going to become better. Now the second concern is, being an adult, he has a chance of getting a restrictive left ventricular physiology. So Dr.
Yeah, I agree with all of that. I guess I was just pointing out, you do have elevated PA pressures here, but in these patients who have a lot of left to right shunt, you often find the PVRI is very low. And so when I see a really good left to right shunt, I feel much happier.
Yeah. So the second question is about the restrictive left ventricular physiology. I want a small bowl of water. So in order to ensure that he doesn't get into a left ventricular end diastolic, left ventricular restrictive physiology, we do a LV end diastolic pressure assessment, and our LV end diastolic pressure here was marginally higher, around 16. The 16 is not prohibitively high, and so we are just going to watch with a complete occlusion how things are. I'm removing the dilator underwater seal now, keeping the wire intact so that the sheath does not go and get hitched against the pulmonary veins. And now I take out the wire. There is a free backflow of blood back through the side arm of the sheath. So now I'm going to aspirate and then flush the sheath. So take a...
Is there any ASD that you would not close using intracardiac echo?
Okay, I mean, if the ASD is quite large with extremely sort of poor margins, the ability of the intracardiac echo to show the defect is going to be poor, and so in those cases it will be our preferred approach to go for a transesophageal echocardiogram. If the ASD is sort of moderate in size, then we can have the two options. In patients who are having excellent transthoracic windows, we just do it on transthoracic echo guidance itself. But in a patient who is around 50 or 60 years, this gentleman is 64 years, who has got a little like not so beautiful transthoracic windows, we would like to use intracardiac echo. Intracardiac echo, in view of the expense of the probe, is not our preferred option in all the cases. We do it very sparingly. The probe is prohibitively expensive. So now Dr. Srija measured a size of 25 millimeter, and our previous echocardiographic measurements were 23. So we have decided to choose an Amplatzer septal occluder, 28 millimeter, and we are going to deploy it in the sort of conventional manner. So I'm just adjusting my ICE probe.
So do you use this on an AP view? Is that correct? Do you leave this in AP view?
Yeah. It's our preferred practice just to use AP view. So I have deployed the full LA disc, and now I'm coming progressively closer. So I will try to get. So we are just going to be coming pretty close to the retroaortic margin. So at this point, I release fluorostore this. So run the fluorostore.
Do you think is there any role for balloon sizing anymore?
We don't balloon size a standard atrial septal defect at all. We use balloon sizing for patent foramen ovale in order to understand the length of the tunnel and also to find out whether it is too stretchable. We use balloon sizing whenever we are going to be using multiple ASD devices in multiple holes. Like if there are 2 holes and we are going to be using 2 devices, we independently interrogate each one. The purpose is to ensure that we are not crossing 2 sheets with the same guide wire. Raghu, can you get the LV and diastolic pressure remeasured? Go
Yes,
in
sir.
as I'm talking.
Yes, sir.
So what we do is in patients with double ASD, we cross one of the ASD, put in a balloon, occlude it, and then use the guide wire to cross the second defect through another access, so that we don't accidentally put in 2 wires and realize it at the last minute that both our sheets were through the main defect. Apart from these multiple defects and then the patent foramen ovale, usually we don't do it at all. However, I would also like to say that if I am having an extremely older patient who I anticipate a substantial restrictive left ventricular end-diastolic pressure elevation and a restrictive LV physiology, in those patients I do a balloon testing in order to find out what is the amount of elevation of the left ventricular end-diastolic pressure and the amount of elevation of the left atrial pressure. Sometimes we take 2 parallel wires. One balloon goes through closes the defect, and the second catheter is in the left atrium to directly measure the LA pressure. So apart from this, in a standard atrial septal defect, we hardly resort to balloon sizing. What has been the practice in Auckland, Cambridge, and all your places, Claire?
So we routinely balloon size.
Yeah.
We do it.
I'm
interested. I'll pass this along, but I'm quite interested in what you're going to learn from this EDP measurement. I'm sort of not sure about that. But
yeah. Can you
can
you show the hemodynamic live now? Take away our pictures. Show the hemodynamic live. Hemodynamics live. Yeah. So this is the left ventricular end-diastolic pressure. It's somewhere around 16. Make it in 20 scales.
So when do you decide to pull off the device? What pressure measurements would it be?
If it goes to something like, say if it touches 20, then what I do is I give an intravenous furosemide to find out whether we have given a lot of fluids. Right now it is somewhere around 18. The baseline in this patient, Dr. Raghu measured as somewhere around 16.
Yes, sir.
So from 16 it has gone up to 18. It's not too alarming. I think I'll be able to manage this patient with medications. You also observe that he's quite systemic hypertensive. See, he's conscious, and I'm doing this live demonstration, and so he's listening. So obviously there is going to be a little bit of anxiety. Sister, can you give me one dose of Lasix, about 40 milligram intravenous? Sir, relax, okay? Everything is going on well. The hole is getting closed. Nothing to worry. Okay? Be cool. So,
Jenny, do you balloon size?
I send all the bad ones to clear. Yeah. Yeah, we pretty much do a balloon size with just a stop flow diameter and
Correct.
go with it. Sometimes actually the borders of some borders are so thin that when you do, even we are only doing a stop flow sizing, you are surprised the amount that the balloon do extend and might upsize your device.
Can we look at the eyes images, please?
Yeah, show the eyes bigger. Take away the fluoroscopy, eyes. Take away the fluoroscopy and eyes, show the eyes. So this is the tricuspid valve. That is the mitral margin that has gone. This is the aortic margin.
It seems straddling very well on the short axis of the aortic valve.
Yeah.
Claire, would you have chosen a larger device? Claire? You have chosen a larger device?
Srija, we can swap over the thoracic and show us.
I'm finding it a little bit hard. I was just saying I haven't done a lot by ice. I did one on a guy who was really high anesthetic risk, but I find it a little bit harder to judge on the images we've seen so far. But I'm sure they've got someone there who's had a good look. But yeah. It does seem to be moving a little bit. You know.
Would you test the safety of the device? Would you pull and push?
Yeah,
on the
yeah.
device?
So right now I will do that for you. I'll just bring down the eyes probe a little bit. Now I'm going to be, so this is a pull and a push. Okay, we are now, it seems okay to me.
Looks very stable.
Yeah. So for 40 milligram furosemide given? Okay. Give also a touch of fentanyl to him. He's probably anxious. A tiny dose of fentanyl. So now we are showing a thoracic echocardiography, even though it is marginally suboptimal. In still Srija is managing good quality images.
So Dr. Sivakumar, when you are closing this, if you find some of the margins have got fairly flimsy borders, in those scenarios, do you go with the 3D imaging sizing or would you balloon sizing? That's kind of where I find that balloon sizing becomes useful.
I agree.
Because it gets much bigger than what we expect on an echo.
Yeah, we stopped balloon sizing about 12 to 13 years ago. Except on those three indications that I told. One is a multiple ASD, and second is a PFO, and the third is a patient with an elevated left ventricular and diastolic pressure. In all the other patients, we sort of we shy away from a balloon sizing. This is the parasternal short axis images. You are able to see that small aortic nubbin of tissue is being caught, and so this is the cable going through the inferior vena cava, and on the other side you are seeing the. Can you make the echo bigger? Echo bigger.
So in that scenario, do
Echo,
you find
yeah.
do you have to upsize your device after deploying one, or do you get much embolization, or you pretty much hardly ever see that kind of thing without?
Yeah, actually we do quite a lot of ASDs here. Our volumes are like maybe 150 to 200 in a year, and if I basically in India, many of the operators, they just go by thoracic. I mean, a non-balloon sizing approach. We do a reasonably large number. We try to make this particular procedure reasonably simple. Can you zoom on that, Dr. Srija? Here, actually, right now we are on a subzified view. You are able to see the superior rim and the posterior rim going between the devices. Zoom on that. Yeah, fine. Yeah. So the device is reasonably well in place, and you like color now. It's looking quite good. About embolization, we too had our share of embolization, but we have overcome it in the last maybe 10 years or so. We had a learning curve when we started using the Amplazer products in the early 2000s, but now I can say that this device is reasonably secure. I'm leaving the left ventricular catheter there. The next step that we do is we just advance the sheath and I release the device. Now this is a 28 Amplatzer device. The device, the intracardiac echo showed a size of 25, was circular. The transesophageal showed 23 and it was circular. The intracardiac echo showed a maximum size of 25. So I'm going to be showing, left ventricular end diastolic pressure continues to be around 16 to 18. Still he is quite systemic hypertensive. We will control his hypertension. We can start on some small dose of nitroglycerin. Yeah.
Dr. Sivakumar, we have also had occasional embolization. In your practice, what is the independent predictor of device embolization?
Okay, actually, I would say that our device embolizations are rather predictable. I'll tell you how we get into that. There will be a patient who will not have a completely deficient IVC margin, and we will advise the patient that surgery is the best option for the patient. There will be a few group of patients who will insist for a variety of reasons, either cosmetic or the fear of surgery or variety of reasons. They will still say that, fully understanding the complexity of this particular procedure, they will still say, why don't you go give a try, and if the device is slipping out, then I will accept that I have to go to the surgeon's table. Otherwise, give me a chance and let me work on it. This happens especially if you have treated 2 or 3 members in the family with a device closure or some sort of percutaneous interventions, and then subsequently you say for the 4th patient that you have to go for surgery. That patient does not accept it at all. So in those cases, we sometimes do it. We explain to them that there may be a possibility of embolization. There are some methods in which we anticipate whether it is going to embolize. We have published in catheterization and cardiovascular intervention a paper called a snare assisted device. That means after putting in the Amplatzer device, we take a snare around the cable, we go and hook the screw end of the Amplatzer device and then release the cable. The cable gives a sort of a perpendicular right angled rigid orientation, whereas when you release the cable, the device flips out into the plane of the atrial septum, and during that particular moment, if there is a possibility of embolization, it's going to embolize. But still, the hub will be caught by us, so we will be catching it. So it will not fly out into the heart. So I would say right now the embolizations, if they happen in a sort of predictable manner and in a controllable manner, so that we are already holding the device even before it flies towards the right ventricle or the pulmonary artery. So it will be interesting if in case if you have not looked at the paper. This was published I think about a couple of years ago in catheterization and cardiovascular interventions, maybe 2000? APC. Sorry, it's in the Annals of Pediatric Cardiology. Was it in 2000? 2017 end or maybe 2018. It's called as a snare assisted technique of release of ASD devices. Right now, as I am talking to you, I am showing an apical 4-chamber view for quite some time. You can see that the device is rather sleek because we have not oversized. In general, in India, we don't oversize more than 3, 4, at the maximum 5 millimeters. And so, fortunately for us, we don't see erosions at all.
Did you give antiplatelet agents? Antiplatelet.
Always antiplatelets. The patient will get aspirin alone if the device is reasonably smaller. This gentleman is now 64. He is having a sinus rhythm. He has a reasonably large device of 28 millimeters, which will have around 44 millimeter left atrial disc. So I'll be happy to give him aspirin and Plavix to both together, and then about 3 months later stop his Plavix, 6 months later stop his aspirin. Dr. Raghu told me that his coronary angiogram is normal, and so probably he does not need. I think he's also a hypertensive, no, Dr.
Yes,
Raghu?
Hypertensive and diabetic.
I think it may be a good idea to keep continuing on aspirin for a longer period of time also. What is
Yes.
your policy on antiplatelets? This is the subxifoid view that I'm showing, zoom.
Yeah, in Singapore, we give the same as you, so it's 3 months of DAPT and then another 3 months of single antiplatelet. But it's actually quite variable, the practice across the world. Maybe I'll just ask also the panelists, what do you guys do?
Yeah, we routinely give 6 months of aspirin. I've used Plavix a little bit more in people who've got a history of migraine because, you know, I've given a couple of months of Plavix, but I don't routinely give Plavix. And the last couple of times I've done that, people have called me up and said they hate the bruising and they want to stop the Plavix.
Yeah, I think this gentleman has got some comorbidities like diabetes, some hypertension, and so I probably may even consider giving him aspirin for even a much more longer period of time. He may have some subclinical atherosclerosis here and there, and it may be worth giving him a longer period of aspirin as well.
Sanjeev?
Yeah, no, so we use 6 months of aspirin with Plavix for at least 3 months, but we continue with them until we actually do a bubble study to ensure the hole is fully closed. At that time, we know the device is not very well ended life coming off any.
Yeah, that is the protocol that we also follow in patent foramen ovale. When it comes to atrial septal defect, usually we don't do this bubble test at all. So in patients who have a previous positive bubble test and a PFO with a documented previous stroke or a previous, like for some rare cases of migraine that we might close, we always do a bubble test before we stop the aspirin. And even the duration of aspirin in those patients with a previous history of a stroke will go on. Like I sometimes even leave it for 1 year, 1.5 years. I don't stop it strictly at the end of 6 months. Now this
BP is still 200.
Dr. Sivakumar, we are running out of time.
Yeah, sure.
We are really humbled that you were able to show two very interesting cases in time. You covered it all in an hour. Very impressive team that you have, and very impressive imaging, and your skills are exemplary. The panel and the chairs and the entire audience here from New Zealand, thank you very much for joining us. We really appreciate it.
Yeah, thank you. Actually, I have not personally, hello, are you with me? Yeah, so we have not personally met each one in the past, except that I know Claire and Dr. Nigel Wilson, who was Claire's senior colleague. Apart from those two doctors in New Zealand, we have not met any other doctors, but I would like to say that it was a pleasure for us to come live and interact with you and take a lot of inputs from all of you. Dr. Jerry was quite experienced person in paravalvular leaks, and so to get his inputs. I also would like to thank my entire team here who started early in the morning at 5 o'clock. There were about 25 persons working in this cath lab. I would like to thank Mr. Ravi, our senior cath lab technologist, and Teresi Amma, our senior cath lab nurse, and a whole team of people. You can see so much of people here. And we were actually, when I told that the New Zealand wants us to go live, the entire team was quite energized and they said that let it be even 4 o'clock in the early morning, we'll transmit. So
Thank you so much, team. We really appreciate it.
Thanks a lot.
Thank you, Dr. Sivakumar. Best wishes. Bye-bye.
Bye-bye.